Welcome to this learning opportunity. I am Teresa Brown with the New Hampshire Tobacco Prevention and Cessation Program, and I'm so pleased you could join us for this module on supporting pregnant and postpartum women to quit tobacco. This video is one in a series of lessons available to increase your knowledge, skills, and confidence in working with patients who use any form of tobacco. The time you spend watching this video will help you work more effectively with your patients. In the next 30 minutes, you will hear from a variety of providers who work with women who use tobacco before, during, and after their pregnancy. They will share their insight and experience in how they motivate women to consider quitting and support them along the way in this challenge. We want to encourage you to connect your pregnant and postpartum patients to as many resources as possible to help them be successful in quitting. Services like home visiting, lactation services, and 1-800-QUIT-NOW not only offer critical support services to help your patients have a healthy and happy pregnancy, but they also provide your patient with the extra boosts and reinforcement to quit. In this module, you will hear from each. You'll receive 0.5 continuing education credits from the North Country Health Consortium, Northern New Hampshire AHEC, after you complete the assessment and evaluation of this lesson. Instructions to apply for credit are provided at the end of this video. You can start and stop this learning activity at any time, and you will receive a CME or CEU after successfully completing the assessment and the evaluation form. After this learning opportunity, you will be able to understand the unique issues related to supporting pregnant and postpartum women to quit tobacco, confidently provide a robust, tailored response to pregnant and postpartum women, make appropriate referrals to resources such as 1-800-QUIT-NOW, and home visiting services.
In this video, we'll talk with various providers to learn how they actively engage pregnant patients in these challenging conversations. I want to also mention the other videos in the series where you can learn the details of making a referral to the services at 1-800-QUIT-NOW New Hampshire, learn about the use of the 7 FDA-approved medications for tobacco cessation, and learn how to incorporate motivational interviewing techniques in your approach. These videos will cover effective strategies to tackle challenging conversations and give you practical ways to respond. My name is Daisy Goodman, and I want to thank you for taking the time to learn new ways to support the women you serve who smoke. Given all the screenings and information we have to cover during a routine prenatal visit, addressing quitting can seem insurmountable, especially when a patient seems to have no desire to change.
The way that we support women in our program to make a change when it comes to tobacco is we really meet them where they're at. We ask the question, we don't avoid it. We talk about smoking and how much are you smoking and how are you feeling about your smoking. It's a topic that's just regularly coming up as we're meeting with families. And we're talking about the effects on the baby of smoking in a gentle way that's non-judgmental, taking into account how difficult it is to quit smoking while also realizing that continuing to smoke could have a negative effect on the baby.
We know that pregnancy is a special time in a woman's life, and she might be more motivated to quit tobacco for this reason. Women who are referred by their provider to 1-800-QUIT-NOW have special services that are available to them. First, all pregnant women are assigned a female coach, and these coaches not only have gone through special training for tobacco treatment specialists, but they've also gone through robust training in pregnancy and how tobacco use interacts with pregnancy and postpartum and secondhand smoke and things like that.
The single biggest benefit to having home visitors working with pregnant women who are using tobacco is that we have a relationship that we're building with a woman over time to really look at why they're smoking and what are the barriers to quitting, and that within that supportive context we can help them to make changes that are positive.
All pregnant women receive 5 scheduled coaching calls during their pregnancy and an additional 4 coaching calls in postpartum. And the purpose of that is to really try to work with these women to keep them smoke-free after their pregnancy.
So our services can support healthcare providers because we have the opportunity to serve women long term. We can serve them throughout the pregnancy and following the birth of their baby, which is a common time of relapse.
Relapse after having the baby is very common with pregnant women, so the coaches really work hard to start planning immediately for handling those types of situations, so the woman does not have a setback or relapse once the baby's born.
If they relapse and start smoking, we can help them get back on track. And we also find that it's really important to look at reduction. Sometimes a mom doesn't quit right away, but she might reduce, and she might listen to what we're saying and say, the next week we come back and she says, I cut down from 1 pack to a half a pack this week. And so we celebrate that success. And it may not be the goal that we want to get to, but it's along the path. And so we continue to support her and encourage her in reducing her smoking and talk about the benefits of even that happening. So when we're talking to women about quitting smoking, there are some common barriers that come up. One is that it'll be really stressful to their baby and to them to quit smoking. And so we talk about that. It is stressful to quit smoking. It's a huge life change, and a lot of women that we're seeing have been smoking for a long period of time. So we want to first of all validate that, and we want to continue the conversation. So if this is going to be stressful, what can we do to reduce that stress? Look, just like we're doing in all the other areas that are stressful in their lives. So to give some tools to reduce stress, because it's worth it. So we do hear that smoking is like a friend, or it's something that I do for myself. It's the one thing I have left. I don't drink anymore. I don't use anything anymore, but I still smoke. And so we validate that too, and try to expand and see if maybe there are some other more healthy things that you can do for yourself, because we do want to have self-care as part of a mom's routine and want to build that into their daily lives. But sometimes smoking seems like it's really a helper when it's not a helper. And so within the context of the relationship with the home visitor, hopefully we can look at these other options that are healthier for mom and baby. Another common barrier is, I'm already gaining so much weight with this pregnancy and I don't want to gain more by quitting smoking. So we talk about that. We can talk about what your diet can be like and getting some exercise, which is also good for you and for your baby, and would just support the quitting smoking process because you'll feel better as you're quitting. The providers, if they could refer to the home visiting programs across the state, that would be amazing, and we can work together to try to help moms quit smoking.
Another special service that 1-800-QUIT-NOW provides is if that provider chooses to prescribe NRT for their patient, that can be mailed out by the 1-800-QUIT-NOW services to the pregnant women, as long as they have a script from their provider. Last, the pregnant women and new moms, if they call 1-800-QUIT-NOW and talk with that special pregnancy coach, they can talk with them an unlimited amount of times. Although they have that 5 scheduled calls and 4 follow-up in postpartum, they can call anytime and speak with a quit coach. To reinforce the coaching sessions, 1-800-QUIT-NOW mails specific pregnancy-related materials with content that is specific to quitting during pregnancy. These materials speak to the unique concerns that pregnant women and new moms might have regarding the impact of quitting on their pregnancy, living with smokers, the safety of using medications, concerns with breastfeeding and smoking, and the exposure to secondhand smoke.
As lactation consultants, we can really be a great member of the team in helping moms to quit smoking, especially if they have some really strong goals around where they want to be with breastfeeding. Breastfeeding, similarly to pregnancy, is a real incentive to get moms to try to quit smoking or to continue cutting down on the amount of smoking that they're doing. And so we really can use this as a great time to help moms reach their smoking cessation as well as their breastfeeding goals. Oftentimes we hear moms say, oh, I can't breastfeed because I smoke. And it's really important that we're giving these moms a message that the actual risk of not breastfeeding at all really outweighs the risk of breastfeeding and smoking. And so while there will be nicotine in mom's milk, that benefit of breastfeeding really outweighs the risk of smoking. And so there's simple tips that we can give moms, such as smoking after she nurses her baby, or just like moms who choose not to breastfeed, you know, keeping infants away from secondhand smoke or changing clothes after you smoke cigarettes. So many moms, when they meet with their lactation consultant, will ask questions like, what options are available to me to help me quit smoking? I really want to reach my breastfeeding goals. And so typically, when they start asking about what medications are available to them, we'll refer them back to their provider to talk about what best meets their needs. But as lactation consultants, we use this really great resource by Dr. Thomas Hale called Medications in Mother's Milk. And it really talks through the different options that are available for nicotine replacement therapy and which ones are best used during lactation. And so most of the studies that you'll read will say that it really depends on the method that mom chooses, so whether gum or lozenges or a patch, as well as the timing of that method is really what's critical for the impact on the baby, because just like smoking, the nicotine is going to be present in the breast milk, but really we can control some of the timing on the delivery of that for the impact on the infant. I think the main message as lactation consultants, whether we're working in a hospital or working in outpatient or working in community programs, is that our message is that the benefits of breastfeeding outweigh the risk of smoking. And so we know, all of us, that breast milk provides so many protective health factors, protects babies against sickness and illness, and many of those can even counteract some of the effects of smoking. And so if a mom is not able to quit, then what better than to help support a healthy life for her and her baby than to help support that breastfeeding, which provides so much benefit.
Another thing to consider for those who have tried to quit but have been unsuccessful is to use one of the FDA-approved medications. Women will be referred back to their providers to discuss those options.
Something that's important to remember is to always conduct a risk-benefit analysis and know that the benefits of using nicotine replacement therapy or smoking cessation medications almost always outweigh the risk of continued cigarette smoking. I think that providers should not be afraid to really thoughtfully utilize the help of pharmacotherapy and cessation aids if necessary. If a patient has tried behavioral therapy and failed, and they're kind of at the end of the line, this is absolutely an appropriate recommendation and suggestion for the patient to try as a next step for sure. I would say some of the most important things to emphasize when deciding whether or not to use pharmacotherapy would be education and a risk-benefit analysis. All of the products that are approved and available for smoking cessation carry a lower risk than continued smoking, and I think it's important for providers to know that and for them to be able to make their patients aware of that fact, because it's so important that even though there may be some small risks with using some of these products, it still is far less of a risk than if they were to continue smoking throughout their pregnancy. Also, a lot of these products are only used short-term. They're not used continuously throughout an entire pregnancy versus smoking, which can be continuous throughout an entire pregnancy. Zyban or bupropion can also be used during pregnancy. It should be used with caution and it should be used with a risk-benefit analysis, but also should not be withheld if it is an appropriate treatment for a patient. Another consideration with pharmacotherapy and when using bupropion would be if a woman is choosing to breastfeed. This medication is really not compatible with breastfeeding and is of concern. So if a woman is breastfeeding, then you may want to choose a different option for therapy, either nicotine replacement therapy or Chantix. Pregnancy does have an impact on the effects of some of these medications, and that's something that definitely needs to be taken into consideration when prescribing any of these treatments. The metabolism of nicotine increases throughout pregnancy, and therefore so does the response to nicotine replacement therapy. Nicotine dosing should be adjusted throughout the pregnancy, and it should be adjusted based on patient symptoms. Also, dual therapy should always be used in pregnancy due to this increased metabolism. A long-acting therapy like a nicotine patch should be matched along with a short-acting therapy like a lozenge or a gum for the best effects. Also, again, the doses may need to be higher than a standard dose, also may need to be adjusted as the pregnancy progresses, as the metabolism continues to increase throughout the pregnancy. And then again, never use cessation medications before first trying behavioral therapy. That is really important. It's the safest way to go. Obviously, if we cannot have any medications be used, that would be the ultimate, but as we all know, some people do still need the help of additional therapies to successfully quit smoking.
Other information I share with patients when talking about smoking during pregnancy includes that nicotine readily crosses the placenta and concentrates in fetal blood, amniotic fluid, and breast milk. That concentrations in the fetus can be as much as 15% higher than they can in the mother's maternal serum. That growth restriction seen in infants of mothers who smoke does reflect a dose-dependent relationship. So if a woman smokes more during pregnancy, we will see greater impact, and if she smokes less, the harm will be reduced. That tobacco use is associated with a greater impact on birth weight even than illicit drug uses in many cases. What once started as a voluntary behavior becomes involuntary, and the brain becomes increasingly sensitive to stress and negative mood around tobacco. So people often say that the brain has been hijacked by the tobacco use. Similar to other addictions, people who smoke find themselves smoking more and more frequently than intended. They're preoccupied with their next cigarette, and they smoke at the expense of other opportunities. In pregnancy, women continue to smoke even though they're aware of the harm that is caused by smoking, and that in itself is a telltale sign of addiction. So when we work with women who are smoking, it's very important for us to help them understand this as a true substance use disorder, and to give them as much credit and support as we would if they were trying to abstain from any other substance. We know, given that smoking is a substance use disorder, that relapse is a common and expected thing to happen. We also know that during pregnancy motivation is very high, and that postpartum motivation will wane because the fetus is now external and the mother's not as concerned about causing harm. And so therefore smoking cessation work during pregnancy and the postpartum is especially important to do repeatedly, and to be very persistent with. We also know that women who smoke, especially during pregnancy, are more likely to have low incomes, lower levels of education, co-occurring depression, and high stress levels. And for that reason, they need a lot of support. And referring them, for example, to the coaches at the 1-800-QuitNow New Hampshire is a good strategy, as well as continuing to raise the issue at repeated visits. So women will often say to me, I've been told that if I quit smoking, my baby will go through withdrawal in utero, and that's really bad for my baby. So clearly they're thinking a lot about harm reduction to the fetus. So that's a woman with whom I would talk about nicotine replacement and a taper, because she'll have more success if she doesn't try to quit abruptly, and also because she will allay her concerns about an abrupt discontinuation on the fetal side as well. In reality, because there are so many toxic ingredients in tobacco, particularly if it's smoked, and she's also transferring carbon monoxide to the baby, abrupt discontinuation would also be better for the pregnancy. But I'm very conscious of her concerns, and although I could explain that, I want to work with her to find the approach that really works for her.
What are e-cigarettes anyway? These are plastic or metal devices that deliver an aerosol in which nicotine is dissolved. Some look like cigarettes, but they come in many shapes, colors, and sizes. These devices have a microprocessor that controls a battery-powered heater. When the sensor detects a person taking a drag, the heater will aerosolize some of the liquid containing the nicotine, creating an aerosol that the person inhales. The tiny droplets dissolve in the lining of the mouth or the upper airway, and with the newer products, the droplets are so small that they actually go all the way down into the lungs. So the nicotine is absorbed in a way that's similar to smoking a cigarette. The liquid is called e-juice. It may contain nicotine at varying levels. However, some people use e-cigarettes with no nicotine in the e-juice. The e-juice may also contain flavorings, and some of those flavorings are made from chemicals that are not healthy to take in. A typical cartridge for an e-cigarette would have about 2 packs of cigarettes worth of nicotine in it. Clinicians have a lot of questions about nicotine in particular. Nicotine is the ingredient in tobacco that's addictive. Using e-cigarettes with nicotine regularly can lead to nicotine dependence in the same way use of any tobacco product can lead to nicotine dependence. Nicotine in the doses people use in cigarettes is not thought to cause cancer or other diseases. However, in large amounts, like in the amount you would get in a bottle of e-juice, nicotine is dangerous. And for that reason, nicotine should be stored safely away from children. Everybody's worried about the safety of cigarettes and e-cigarettes for pregnant women and for developing fetuses. The toxins in smoke cause pregnancy complications and harm to fetuses, but these toxins are present in a much lower level in e-cigarette aerosol. Nicotine causes tightening of blood vessels that slows fetal growth. Nicotine also affects the neural development of fetuses. As of 2017, the level of toxins in tested brands of e-cigarettes were much lower than the amount of toxins in cigarette smoke, between 8 and 600 times lower. Many carcinogens found in cigarette smoke were simply not found in e-cigarette vapor at all. The problem is that most brands of e-cigarettes have not been tested, and we really don't know about the safety of e-cigarette use in pregnant women. The FDA is requiring that manufacturers submit safety data of e-cigarettes by 2022. But until then, we simply don't know for sure how safe e-cigarette aerosol really is. So who's using e-cigarettes these days anyway? In adults, e-cigarette use is most common among smokers who wish to cut down or be healthier or to quit smoking altogether. It's clear that some e-cigarette users are successful when quitting smoking. The sum of studies now suggests that many smokers who are trying to quit do use e-cigarettes, and overall use of e-cigarettes among American smokers trying to quit doesn't increase or decrease their chance of quitting. So what should clinicians do when a person they work with says they're using e-cigarettes? Well, first, clinicians should find out the reasons people are using them. We can empathize with how difficult it can be to quit tobacco, and then we can educate people with the facts about e-cigarettes. If smokers are using e-cigarettes to cut down or quit, we should support those people's smoking cessation efforts. We can link people to cessation resources. We can consider encouraging people to try safe, FDA-approved nicotine replacement therapy. We can help pregnant women overcome barriers to cessation. We can identify and treat depression and other mental illnesses in these folks. We can link them to counseling that helps them manage negative emotions without smoking. We can provide and link people with supports to reduce stress. And we can help women's partners who smoke to quit smoking with her. Even with this encouragement, smokers may still want to include e-cigarettes as one of their smoking cessation strategies, but we as clinicians can still work with them to cut down and quit smoking because this is so important for people's future health. Teaching people behavioral cessation strategies will help them quit smoking, and eventually it can help them give up e-cigarettes in the future as well.
The Medicaid tobacco cessation benefit provides members with free and low-cost access to evidence-based tobacco treatment. The comprehensive benefit includes medications, counseling, and referral to the 1-800-QuitNow helpline. The Medicaid program also provides reimbursement to providers for providing the tobacco cessation counseling, and that should be noted that that is in addition to the office visit that is provided. The counseling sessions do have some limitations. However, the Medicaid program allows up to 16 individual and/or group counseling sessions, for which we call quit attempts, and they are covered if they're performed by either a physician or a physician's assistant, advanced registered nurse practitioner, or a mental health counselor. Medications are part of the comprehensive tobacco cessation benefit. Medicaid-enrolled providers can prescribe any of 7 FDA-approved nicotine replacement therapy and non-nicotine containing medications, all of which are on the New Hampshire formulary. The medications are available to any New Hampshire Medicaid member at local pharmacies who also need to be enrolled as New Hampshire Medicaid providers as well. There are copays for the medications, $1 for the preferred and $2 for the non-preferred. There are no prior authorization requirements, however. Additionally, the 2 Medicaid contracted health plans, New Hampshire Healthy Families and WellSense, provide additional incentives and enhancements to pregnant and postpartum women. The enhancements and benefits are not the same between the 2 plans, so women need to, when they choose a plan, make a decision about the incentives and which ones would be most important to them. Some of the enhancements include free car seats, diapers, incentives for keeping appointments. In addition to the Medicaid benefits that have been described, of note, one of the Medicaid contracted managed care companies also offers a financial incentive to pregnant and postpartum women for completing counseling sessions.
Another module in this series is called the Fundamentals of QuitNow, New Hampshire. That module really explains the details of the services available and how to make that service fit into your practice's workflow. Please watch that. There are several quick and easy ways to refer women. You can adopt any one of these methods or all of these methods into your practice's workflow. I will briefly cover the 4 ways to link your patients with services at 1-800-QUIT-NOW. First, providers can educate their patients about the services and encourage them to call directly. Downloadable material to promote 1-800-QUIT-NOW is available on our website. A good way to reinforce the discussion you had during your visit is on the after-visit summary sheet that the patient takes with them, is to make a note that this was discussed and the 1-800-QUIT-NOW number. Next, providers can fax the universal referral form that is available on QuitWorks New Hampshire website. Available at QuitWorks New Hampshire website is also an online web referral. Simply complete the online form and email it directly through the website. Both ways of faxing are HIPAA compliant. The 4th way to refer patients is through your electronic medical record. While this method is very efficient and effective, there is a cost associated with setting it up. I am available for consultation and training to help you set up this protocol, so please do not hesitate to call me.
Thank you for taking the time to complete this module. To receive a Certificate of Completion, or CEU, for this lesson, you need to complete the 2-part assessment. The links are at the QuitWorks New Hampshire website for you to click through to a survey.